Good morning and welcome to this session titled Tobacco Control Policy, Prevention, Harm Reduction and Cessation. I'm Karl Lund. I'm co-chairing this session with Professor Anastasia Barbouni, who will present herself in a minute. Myself, I'm a senior researcher at the Norwegian Institute of Public Health. I've been involved in tobacco control work since the mid-1980s. I've been a member of several expert committees, including the WHO International Agency for Cancer Research, and I'm also an associate editor in nicotine and tobacco research. Now, we have two lectures in this session, followed by a panel discussion. And now I will give the word to Anastasia to present herself and to introduce the first speaker. So Anastasia, please.
Thank you, Karl. Good morning for me. Nice to meet you here in a virtual congress, and we have a very interesting topic in our topics in our session. And now I want to introduce myself. I'm a pediatrician. I'm a professor of public health at the University of West Attica, and I'm director of a special academic unit for the study for smoking behavior. In this unit, we have we're working on the design and the development of some surveys about smoking cessation, smoking habits, and that's why we are here. One of my colleagues and one of my dearest colleagues is Konstantinos Kesanopoulos, and I'm very happy to introduce him. He's biology, and he has studied biology and physiology at the University of Toulouse, and he holds a degree in public health. Since 1916 to 2019, was responsible in a course that we have named Principles of Prevention and Smoking Cessation, and that was the first baptism to her career for smoking. Now he's working with us at the unit, and he's working on the design and development of internet-based surveillance system for the study and monitoring issue of smoking cessation. That's why we want to present now where we are, and I believe that her presentation will be very interesting for our summit. Konstantinos, you can start if you want.
Good morning, ladies and gentlemen. First of all, I would like to thank the organization committee of the summit for giving me this opportunity to talk to you today about the global burden of smoking and what we have achieved so far. Substantially global efforts has been devoted to curtailing the tobacco epidemic over the past 2 decades, especially after the adoption of the Framework Convention on Tobacco Control by the World Health Organization in 2003. In 2015, in recognition of the burden resulting from tobacco use, strengthened tobacco control was included as a global development target in the 2030 Agenda for Sustainable Development. Latest global data finds nearly 8 million deaths from smoking in 2019 and 90% of new smokers addicted by age 25. It is irrefutable that the tobacco epidemic remains an important public health concern, and it is of the utmost importance to ending this global public health issue as soon as possible. During the first part of my presentation, I will try to give you an overview of the prevalence of smoking tobacco use globally and highlight the evolution of the epidemic the last 30 years. In the second part, we will discuss the effects of tobacco control policies on global smoking prevalence the last 30 years from 1990 to 2019 and the obtained results of the implementation of these policies. Few months ago, in June 2021, the Lancet published data from smoking use prevalence based on the analysis of the Global Burden of Disease Study 2019, including data from 204 countries and territories. These countries and territories were nested in 21 aggregate regions and 7 aggregate super-regions. Standard regions and super-regions in the GBD are defined based on a combination of epidemiologic patterns and spatial distance. According to this data, globally, the number of current smokers in 2019 was 1.14 billion. Age standardized prevalence of current use of smoking tobacco among individuals aged 15 years and older was 32.7% among males, with highest prevalence in Asia and Oceania, and 6.62% among females, highest prevalence in Europe and Oceania, of course, with tremendous differences of smoking prevalence between the different countries. For instance, the lowest prevalence among males aged 15 years and older was 7.33% in Peru, and the highest was 64.6% in Timor-Leste. Again, among females aged 15 years and older, the lowest prevalence was almost 0.7% in Eritrea, and the highest was 42.3% in Greenland. According to the data analysis, smoking prevalence exceeded 20% among males in 151 countries and among females in 42 countries. Among the 159 countries with a population exceeding 1 million, the highest prevalence of smoking tobacco use in male was observed in Timor-Leste, Indonesia, Armenia, Jordan, and Georgia, when the highest prevalence of smoking tobacco use among females observed in Serbia, Chile, Croatia, Bulgaria, and Greece. As stated by these findings of the study, there is a concrete evidence that in Greece we have a lot to do about smoking cessation. The 10 countries with the largest number of tobacco smokers in 2019 were China, India, Indonesia, the USA, Russia, Bangladesh, Japan, Turkey, Vietnam, and the Philippines, and together comprising nearly 2/3 of the global tobacco smoking population. I want to stress that 341 million tobacco smokers, corresponding approximately to 30% of the total number of tobacco users worldwide, lived in China in 2019. Since 1999, global age standardized prevalence of smoking tobacco use among males aged 15 years and older decreased by 27.5% and among females decreased by 37.7%, with variable progress across countries. Prevalence of smoking tobacco use among males decreased significantly between 1990 and 2019 in 135 countries, but decreased significantly among females in only 68 countries. The largest decreases were observed in Brazil, where prevalence decreased by 72.5% among males and by 74.7% among females. Across both sexes combined, the largest decreases in age standardized prevalence of smoking tobacco use were observed in Brazil, Norway, Senegal, Iceland, Denmark, and Haiti. In the opposite, prevalence of smoking tobacco use increased significantly over the past 30 years in 20 countries for males and 12 countries for females. In Afghanistan, for example, the prevalence was increased by 179% among males and 205% among females. Another important point that needs to be taken into consideration is the rate of the fluctuation of the smoking prevalence during this 30 years period. According to the analysis of the annualized rate of change per 5 years period in individuals aged 15 years and older again, between 1990 and 2019, the largest number of countries had their fastest decrease in age standardized prevalence of smoking tobacco use between 2005 and 2009 for both males in 68 countries and females in 56 countries. Overall, for males, a percentage of 56% corresponding to 115 out of 204 countries, and for females, a percentage of 67% corresponding to 136 countries, had their fastest decrease after the World Health Organization Framework Convention on Tobacco Control, which was ratified after 2005. Notably, decreases in prevalence were smaller in the period 2015-2019 than in the period 2010-2015 in 152 countries for males and 137 countries for females. These slides show the evolution of the rate of change in number of tobacco smokers by 5 years intervals. Both lines show regional averages and thin lines show country-level changes. Important differences of the rate of change were observed between regions, independently their geographical position, their continent, or their economic situation. In the top left corner, we can see the rate of change in number of tobacco smokers globally throughout the 30 years, and in the bottom left corner, the rate of change of the age standardized prevalence of smoking tobacco use. In many countries, reduction in prevalence have not kept pace with population growth. As a result, the number of smokers globally has increased steadily each year since 1990, when there were 0.99 billion smokers globally, with the exception of the period between 2011 and 2017, during which no significant change in the number of smokers occurred. Of 204 countries and territories included in the analysis, 113 had a significant increase in the number of current smokers between 1990 and 2019, and 111 had a significant increase between 2005 and 2019. Among both males and females, the super region with the largest relative increases in the number of smokers since 1990 were North Africa and the Middle East, with an increase of 104.1%, and Sub-Saharan Africa with an increase of 74.6%. The largest relative decreases in the number of smokers were observed in the Latin America and the Caribbean, 19.8%, and the high-income super-region, 17.6%. Today, the direct relationship between number of cigarettes smoked per time unit and risk outcome is very well documented. The estimation of exposure of smokers for the non-cigarette smoked tobacco products is qualified as cigarette equivalents on the basis of the weight of tobacco. Conforming to the above, 7.41 trillion cigarettes equivalents of tobacco were consumed in 2019, accounting to 20.3 billion cigarette equivalents consumed each day worldwide. China accounted for more than a third of the world's tobacco consumption, with 2.72 trillion cigarette equivalents. Countries with the highest consumption per person in 2019 were mostly in Europe, with Montenegro, North Macedonia, Bulgaria, Slovenia, and again Greece, all having consumption exceeding 2,350 cigarettes equivalents per person. Countries with the lowest consumption per person were mostly in the sub-Saharan Africa. Cigarettes smoked per day is an important predictor of disease risk, although smokers who consumed only a few cigarettes each day still have considerable excess risk compared with non-smokers. Among 719 million male current smokers aged 30 years and older in 2019, 11.6 smoked 1 to 4 cigarette equivalent per day, 19.4 smoked 5 to 9, 20% smoked 10 to 14, 16.8 smoked 15 to 19, when 32.3 smoked 20 or more cigarette equivalents per day. Among 146 million female current smokers aged 30 years and older in 2019, 18.5 smoked 1 to 4, 26.7 smoked 5 to 9, 22.1 smoked 10 to 14, 14.2% smoked 15 to 19 cigarettes, and a percentage of 18.5% smoked 20 or more cigarette equivalents per day. In other words, the majority of male smokers at a percentage of 32.3 watts smoked more than 20 cigarettes per day, in contrast with the majority of female smokers who at a percentage of 27% smoked 5 to 9 cigarettes per day. The distribution of cigarette equivalents per smoker per day varies also across countries. Most of the male current smoker population aged 30 years and older in 72 countries, and most of the female current smoker population in 121 countries smoke fewer than 10 cigarette equivalents per day on average. Now, if we have a closer look of the number of deaths and disability-adjusted life years that provoke smoking globally, we will see that only for 2019, 7.69 million deaths and 200 million deaths were attributable to smoking tobacco use, accounting for 13.6% of all deaths and 7.89% of all deaths. 6.18 million, corresponding to 80% of this death, were among males, and smoking accounted for the largest number and proportion, 20.2% of death among males of the 87 risk factor included in the Global Burden of Disease study for 2019. Among females, smoking accounted for 1.51 million deaths and 5.84% of all deaths. Of the 36 health outcomes caused by smoking tobacco use, the health outcomes with the largest number of deaths attributable to smoking tobacco use for both sexes combined in 2019 were ischemic heart disease, chronic obstructive pulmonary disease, tracheal, bronchus, and lung cancer, and stroke, which together accounted for approximately 72% of all deaths attributable to smoking tobacco use that year. Top causes of death attributable to smoking varied by region, reflecting differences in both background, cause-specific death rates, and pattern of smoking. Ischemic heart disease was the leading cause of death due to smoking tobacco use in all super-regions except the high-income super-region, for which the leading cause was lung cancer, and for countries in the Southeast Asia, East Asia, Oceania, super-region for which the leading cause was chronic obstructive pulmonary disease. An estimate of 5.96 million, corresponding to 77.5% of 7.69 million deaths attributable to smoking tobacco use occurred in low-income and middle-income countries in 2019. Ukraine had the highest death rate from smoking among males, with 487 per 100,000 males. Countries with high rates of deaths among male smokers were predominantly in the Central Europe, Eastern Europe, and East Asia regions. Among female smokers, 4 locations had rates of death higher than 180 per 100,000 females, and they are Denmark, Montenegro, Serbia, and Greenland. Across all age groups, smoking tobacco use was the cause of more than 20% of all May deaths in 73 countries in 2019, and among females, smoking accounted for more than 20% of death in only 2 locations, Denmark and Greenland, due to both lower smoking prevalence, shorter duration of smoking, and lower smoking intensity among females than among males. This slide shows the global smoking attributable deaths numbers percent rate per 100,000 by 5-year age group for both sexes combined in 2019. The proportion of death attributable to smoking tobacco use increased with age, peaking among those aged 60 to 64 years, 22% of death, before decreasing in older age groups. On the left, we can see the number of deaths in absolute number, where in the middle are presented the corresponding percentages. As already mentioned, the deaths were grouped by 5 years age group, starting of the age of 30. In summing up, in 2019, more than 1 billion people smoked tobacco regularly, and almost 8 million deaths were attributable to smoking. Smoking tobacco use accounted for 20.2% of all-cause death among males and was the leading risk factor for both deaths and DALYs among males. Among females, smoking tobacco use accounted for approximately 0.8% of all deaths due to lower prevalence, shorter duration, and lower intensity of smoking than in males. Tobacco control has contributed to reductions in global prevalence of smoking tobacco use of 27.5% for males and 37.7% for females. However, these global aggregates do not illustrate important between countries heterogeneity. Between 1990 and 2019, significant decreases in prevalence of smoking tobacco use were observed in 135 countries for males and 68 countries for females, while significant increases were observed in 20 countries for males and 12 countries for females. Although tobacco control effort began as early as in the 1960s, in some countries, after the detrimental health effect of tobacco smoking were first documented, global progress in tobacco control was catalyzed by the passing of the WHO FCTC in 2005. The decade following the introduction of the WHO FCTC was the period of fastest decrease in the prevalence of smoking tobacco use across the largest number of countries. The effectiveness of the demand reduction policies outlined in the FCTC articles has been documented, and the large reduction in prevalence of smoking tobacco use between 1990 and 2019 were observed in many countries, as we mentioned before, and show the potential of this tool to operate in diverse contexts to greatly reduce the prevalence of smoking tobacco use and save millions of lives over the coming decades. Despite these successes, in several countries with large population and high prevalence of smoking tobacco use, including China, little to no progress has been made in reducing the prevalence of smoking. Most countries did not have sufficient decreases in the prevalence of smoking to offset demographic force of population growth, resulting in constant increasing numbers of smokers over time. And in many countries, including those that had large decreases in prevalence previously, the rate of progress has slowed, particularly in the past 5 years. 113 out of 204 countries and territories had a significant increase in the number of smokers since 1990, and 111 countries had a significant increase since 2005. To achieve the goal set forth in the SDGs and WHO Global Non-Communicable Disease Monitoring Framework, most countries will need stronger tobacco control policies than those already in place. As of 2018, only 62 countries had comprehensive smoke-free policies. 23 offered the full range of cessation support services recommended by WHO, 91 mandated best practice pictorial health warnings, 48 were protected by completed advertising, promotion, and sponsorship bans, and 38 had the recommended level of tobacco taxation. In conclusion, closing gap in the adoption, implementation, and enforcement of evidence-based demand reduction policies is vital to ending the global health tobacco epidemic. Thank you very much.
Thank you very much. This was a very comprehensive overview of the situation regarding smoking prevalence and mortality, a lot of numbers there. The main message for me in your excellent presentation is that smoking is still a huge problem in most populated and poorest countries in the world. And these countries seem to have a weak infrastructure for tobacco control and would profit from a strengthening of the traditional means of tobacco control, like taxation and regulation, education, assistance, and cessation. But a question from me to you, and you don't have to answer it now, you can answer it during the panel discussion. How do you assess the need for a supplementary strategy of tobacco harm reduction in these countries? Is there a place for tobacco harm reduction in developing countries? What is your opinion on that? But following Konstantinos Kesanopoulos now will be no other than the person responsible for the scientific program of this summit, Professor Giuseppe Biondi Zoccai. And Professor Zoccai is a cardiologist currently working at the Sapienza University of Rome. He's been involved as first author or co-author in more than 200 systematic reviews and meta-analysis. And as a whole, he has co-authored more than 800 articles indexed in PubMed, as well as also editing and authoring several books. So we will now lend our eyes and ears to very qualified and well-published scientists. And please, Giuseppe, you have the microphone now.
Here I am. Many thanks for the introduction. I will now move to the presentation. So basically, the task of the presentation is to provide some evidence on tobacco harm reduction strategies. And it is, of course, an important topic. And first of all, I would like to remember everybody that foremost Italian cardiologist Attilio Maseri has died recently, and I think is an orthodox approach to research and clinical practice, trying to challenge dogmas, is something that we should bear in mind when tackling smoking, which is an old disease. It's not a COVID, but it's still very challenging. This is my disclosure. So basically, it's challenging to summarize what has been published or presented or collected on tobacco harm reduction, because the literature is growing exponentially in the last few years. The key point is that people are becoming aware that this is something viable that can impact patients and healthcare systems substantially. So we know from the prior presentation, we all know that the smoking epidemic is there to stay unless we do something proactively and use a multidimensional approach, which can reduce the burden of this disease worldwide, but also in your family, in your institution, among your friends, and so forth. We are well aware that many support strategies are available and effective, that pharmacotherapy can be useful. It's not game-changing, but the good thing is that these drugs may have some adverse effects, but they are suitable for prescription and reimbursement to patients. So the main change in recent years from snus to electronic cigarettes is the concept of modified risk product. So a modified risk product is a tobacco or tobacco-like product which can modify, hopefully reduce, the global burden of disease associated with smoking. Note, this is very important, that the modified risk product claim is a complex one, multidimensional. It's not the same thing as saying a reduced risk product claim. So the key point is that some products may have a modified, hopefully reduce risk, but this has to be shown. And actually we will have to be aware and cautious for many years, possibly decades. However, it's important to be pragmatic and optimistic in a way, and so we can define typical MRPs such as vaping cigarettes, Blue, Juul, many others, and heat-not-burn cigarettes such as Glow, IQOS, and many others on the market. So what is the dilemma? Should we proactively promote modified risk products to rescue smokers using combustion cigarettes, or should we ban, limit, avoid supporting MRPs in order to save vapers? So where is the balance? What is more effective and useful and ethical for society, for individuals? Of course, there are several pros and cons. For instance, behavioral psychotherapy, replacement therapy, and this kind of thing may have some safety, some efficacy. Efficacy, safety can be reappraised over time, but the key problem with the smokers is the appeal. So it's very difficult to motivate a smoker to give up combustion cigarettes unless we offer an alternative. Also, we don't need to see each of these interventions as a one shot. So you're trying to hit a target and you have only one bullet. In my practice, I've seen people shifting from one MRP to another one, to a softer one, and then eventually cessate, go to abstinence altogether. So we need to see this as a path rather than as an alternative where you are stuck once you have made your decision. And indeed, there is a harm continuum as well, from combustion cigarettes to chewing tobacco, snus, and possibly lower risk MRPs. We have done a lot of research on this. We have tried to capitalize on our experience, to be frank, as former smokers, and the usefulness we recognized in MRPs. We have done several studies on this. We have ongoing studies, a study done in patients with coronary artery disease. We are planning 2 multi-center trials of mentoring of electronic vaping cigarettes and heat-not-burn cigarettes in primary prevention. And after that, hopefully, we will apply for funding for a pragmatic randomized trial in secondary prevention. We have also tried to summarize all the evidence on the safety of MRPs and particularly cardiovascular safety. And we found that indeed we have signals of adverse effects. So MRPs are not necessarily safe, not at all. They have a small but measurable risk. Most of the risk is due to actually nicotine, which is the active agent we are delivering together with all the gestures and the style of the smoker. Indeed, the nicotine has been associated with the acute myocardial infarction, hypertension, tachycardia, oxidative distress, and so forth. Indeed, we're trying to recommend to be flexible and consider MRPs as allies which can support the patient toward cessation and abstinence. And you may think that some people may go on cessating altogether from smoking. Some people will need some counseling, some drug, some replacement therapy. Others will need a vaping cigarette, other a stage heat-not-burn cigarettes, and then a vaping cigarette, and so forth. We don't need to be rigid. However, if we want to be more rigid, we have now randomized trials showing that electronic cigarettes do reduce smoking and are associated with a substantial increase in cessation. This is a meta-analysis of randomized trials published just a few weeks ago. However, no trial included heat-not-burn cigarettes. Also, the Cochrane collaboration just released their meta-analysis on e-cigarettes for smoking cessation. And in this case, we have a comparison versus nicotine replacement therapy, and we have a significant benefit. However, take into account that the study quality is not always excellent. So the internal validity of the trials sometimes is suboptimal. we may also try to summarize the complex alternatives. So nicotine-free control, nicotine replacement therapy, e-cigarettes, and this is what is called the network meta-analysis. And we can indeed see that electronic cigarettes with nicotine are associated with substantial cessation success, as well as nicotine replacement therapy, but electronic cigarettes are superior also to nicotine replacement therapy. If you are interested in statistics, we may discuss this later. There is some suggestion that there could be some bias, some selective reporting favoring some type of interventions. So the jury, in a way, is still out, and we need larger and longer follow-up trials to settle this definitively. But it's clear that cessation rates are increased by using MRPs. Moreover, very recent data suggests that MRPs may also be cost-effective. So on top of being effective, likely reasonably safe and efficacy substantial, they can be a good investment for society. Remember, though, that MRPs are devices to deliver nicotine. Nicotine is not safe. So every nicotine uptake from a patient is going to be a minor hit to his safety, to his healthness, to his well-being. And this is very clear. Indeed, we could envision in the future a transition from a nicotine-rich MRP to a nicotine-poor MRP. Of course, device companies are not very interested in nicotine-free products because they are less addictive, and so they are less suitable to create long-time customers. And this is a major struggle that we need to be aware of now, and especially in the future. What are the MRP effects? Summarizing them, the pros are the reduction in traditional combustion cigarette use, increase in total cessation from tobacco combustion cigarettes, improvements in respiratory symptoms, exercise tolerance, quality of life, and rate of disease exacerbations. Of course, there are cons. We promote nicotine addiction. We may have adverse oxidative and vascular effects, again, mostly due to nicotine, but there might be other agents which are detrimental. And there is also a risk of tampering, especially with custom solutions. We may have lung injury or also the abuse of illicit drugs. The key point, we have uncertainties. There is no data on long-term 10, 20 years safety, overall pulmonary, cardiac, and moreover oncologic, which will require time to test and exclude. Why, if you are a skeptic, should you avoid MRP? Because the cigarette is not vapor. They may have a unique and unknown harm profile, distinct but still substantial in comparison to combustible cigarettes. They may have a threefold increase in serious adverse events compared with the drugs. They can be abused extensively by adolescents, teenagers, and they create nicotine addictive. However, we can think of MRPs as tool, as dangerous but useful weapons to be leveraged. First of all, it's true that most of the harm caused by combustion by tobacco is caused by combustion. So if we avoid combustion, we get rid of the worst enemy. Nicotine, though not benign, is not directly responsible for most of the cancer, lung disease, and heart disease. Although it is not possible to precisely quantify the long-term heart and the other damage of e-cigarettes, available data suggests that they are unlikely to exceed the extent of those associated with the smoked tobacco products. Indeed, it's true that the harm reduction approach is psychologically completely different and thus more appealing for smokers than a smoking cessation mantra. Indeed, this is quoted verbatim. Basically, e-cigarettes, MRPs, are alternate source of nicotine without combustion. They are suitable to achieve significant reductions in risk of cancer, cardiovascular, and respiratory disease. And the recommendation of this author from CHEST is that healthcare professionals should be positive and open-minded towards their use. My conclusions instead are simply that smoking represents the most impactful yet actionable risk factor of cardiopulmonary disease and cancer. Cigarettes and heated tobacco cigarettes are MRPs which may improve cessation and abstinence rates from combustion cigarettes, but may create new smokers or impede eventual total cessation from nicotine addiction. MRPs may have substantial cardiovascular effects, and again, I do recommend their use only when envisioning smoking cessation in patients at low risk and also setting a specific time for eventual discontinuation. Many thanks for your attention.
Thank you very much. In addition to the two excellent speakers we just heard, we also have two excellent panelists with us this morning. And maybe you, Anastasia, could do a brief introduction of the two panelists.
We have with us two very important colleagues, distinguished scientific person in Greece, Professor Ikonomidis and Professor Polyzogopoulou, that can make us some comments about our presentations. Can we start with Professor Ikonomidis?
Yes, thank you, Anastasia. I think these were two excellent presentations. The very first one showed the problem as it is today, and the problem is great. We have 1 million deaths from cancer, from coronary artery disease, and smoking is about 25% of European citizens. So from 25% to the 5% is a huge gap, and it needs to be bridged. What are the solutions? Of course, we have approved medical treatments. There are programs based on medication, on nicotine replacement therapy, on varenicline, bupropion, but still we don't get to persuade people, or we have a lot of relapses. The other option is the harm reduction option, and it was presented very elegantly by Professor Zoccai. This is a very strong weapon, that we have to learn how to use it. I think in UK they have tried this method, and they have seen that if you combine both, if you combine NRTs with, for example, electronic cigarettes, one after another, you can have higher smoking cessation rates. And in any way, by using this method, you get a less exposure to toxicants, so you have less hospitalization and less effect on public health, and of course on health economics, because this is another issue. You need to spare money to face all the range of diseases. So I think we need to discuss the pros and cons, as Professor Zoccai has shown to us. We have to be very careful in young people, in adolescents, because they see all these electronic devices are gadgets. Young people are very prone to use gadgets because they look nice. So, and probably that's one of the minors of the jewels in USA. They look like USB sticks. They can be used within a classroom. So this is not the correct way to present this kind of smoking and harm reduction policy. We need to be very strict on the use, and we have to have some rules and bans in the adolescents, probably discuss on the flavors. Flavors may make them more appealing for the adolescents, and use them in smoking cessation clinics, approved clinics, that they know what to do to whom they will propose and what they will propose to everyone, and individualize the problem of each one. That is the reason that I believe that we need to have smoking cessation clinics where a psychologist will take part, a dietitian will take part. So we'll have to have a holistic approach for the smoker. But these are my comments. Thank you.
Thank you, Professor. Your comment about adolescents was very, very hot topic, because we have noticed that in Greece we have a percentage of children that they appeal, they want to use some of the new products. So it is your comment, it was very essential. Karl, can you introduce the second colleague?
Sorry. Yep. The other panelist is Effie Polyzogopoulou. She's an assistant professor of emergency medicine at the University of Athens. I think she's trained in emergency medicine in the United States, in New York Presbyterian Queens Hospital, New York City. Effie has a leading role, as I understand it, in emergency medicine in Greece, and has served as an advisor for the government and health authorities in Greece. So please, Effie, the microphone is yours.
Thank you. Thank you for the invitation and the introduction. Sorry, can you hear me? Oh, okay. I will speak from my point, from the emergency physician point of view. Usually, traditionally, we have the patient, the consequence of the complications of smoking. We receive patients, and it's quite often to have patients in the emergency department which have presented with acute coronary syndromes, and the only risk factor is smoking. This is interesting because many of them are young, around of 35, 40s, without any other comorbidities, and probably there are many mechanisms which can cause this problem, cardiovascular problems, and like endothelial dysfunction, vasospasm from sympathetic activation, and many others. And we are looking on this. This is interesting and not a good sign. Where are we going? And in our country, we have a huge problem with smoking as well. Regarding the first presentation, both of them, they're excellent and provide me so many information because I'm not familiar with so much familiar with this topic. But I would like to point on one interesting and disappointing find that still, according to the latest data, we have 20 countries, as far as I remember, which has show an increase in smoking prevalence, and for males and 12 for females. This sounds disappointing. It means something regarding preventing measures, campaigns in a universal stage level. I would like, I don't know if we have the, any data regarding the period, COVID pandemic, this period. Do we have any differences in a universal level regarding smoking behavior? I was wondering if we have something about this and what it means. Also, I will say for the second presentation, I was thinking that, of course, we have to provide alternatives in order to reduce the burden, and probably the campaigns of smoking cessation campaigns should focus on not only on the negatives, the cardiovascular complications, cancer, but also on the positives, the benefits of smoking cessation, the improvement of quality of life in ex-smokers. Probably they can share their experience and definitely provide alternatives. That's all for the moment.
Thank you very much, Effie. Yes, I think this afternoon, Professor Ken Warner will be talking about the need for a more balanced consideration of the risks and benefits of e-cigarettes, where the potential risk for young people should more carefully be weighted against the potential to reduce adult smoking. And the background for this is, of course, a very powerful article that was published in American Journal of Public Health a month back, where 16 past presidents of the SRNT, Society for Research in Nicotine and Tobacco, they called for a more balanced perspective. And these eminent authors, they claimed, or they concluded, that the singular focus on decreasing youth vaping has been, in fact, a distraction from the larger goal of tobacco control, namely reducing smoking and its harms. So we're back to the dilemma that Professor Zoccai started with. How should we put more weight on the concern for smokers than for youth? So I would like the panelists or the speakers to have opinion on that. And of course, I also remind Kesanopoulos of my question that was, do we have a place for tobacco harm reduction in developing countries as a supplementary strategy to combat smoking-related diseases?
Yes, Karl, if I can reply to your question.
Yes.
We share, my first comment is that we share the same question. And it's obvious that the questions arise. What about smokeless tobacco products, e-cigarettes, heat tobacco, or other electronic nicotine delivery systems? Unfortunately, I don't have any reply, because it's one of the limitation of the presented data, because they don't include in the study. They only analyze data from tobacco smoking, only that. As far as I'm concerned, of course, incorporating the health effect of the area of emerging nicotine delivery system, of course, including both potential benefits and potential harms, it is extremely important. And I think that we will see such approach in the next few years, or at least I hope.
Yes, I certainly hope so as well. Wonder if some of the other panelists or speakers have an opinion. My question was, in fact, that should we put more weight on the concern for smokers than for youth in this dilemma that Professor Zoccai mentioned? I mean, for smokers, they have lower SES, they're high risk of an immediate smoking-related disease. As for youth, e-cigarette use is first and foremost experimental, and for many temporary. And also vaping among youth also is most widespread in the segment of youth already using a tobacco product. So what's your opinion on that? Should we, is the singular focus on decreasing youth from vaping, has that been a distraction from the larger goal of tobacco control?
If I may, Professor Lund, what we face every day, I'm sure Professor Zoccai has the same impression, in the cardiology clinic, is that there is a patient with a heart attack. Initially, he decides to quit smoking. Usually, according to our data from our hospital, 60% do not smoke the first 3 months. And when we go to 6 months and further to a year, then 60% of these patients have come back to smoking. So there is the bet that we have to win. How can we persuade these people either to stay or to find an intermediate way to go to final smoking cessation? Of course, similar dilemmas will be in cancer patients or in other categories like psychiatric patients. However, this is a reality, and there is, I think, the place for the harm reduction policy. Now, of course, it would be very helpful for us if we had a good smoking cessation clinic, we had the financial support to provide to patients initially as a secondary prevention, an option to go to smoking cessation through this harm reduction procedure. Now, for the general public, this is another issue, and there we need to find the balance and check who are these that they have tried with medication, they have tried with NRTs, and then there is a solution for these new products to them, for them to try another way to go to total smoking cessation or to at least harm reduction. Now, the thing is, sorry for that, how we're going to deal with the young people, how we're going to make these things unappealing to youngsters. So there must be taxation, lack of e-flavors, for example, lack of devices that they look attractive for young people. I said the example for Jules, for example, they are very small, very handy. You know, this kind, I think, of measures should be taken in order to prevent youngsters to use these gadgets.
Yes, I totally agree with Professor Ikonomidis. I think that we have done a lot we have done a lot about smoke cessation in the last 20 years, but we have a long way, especially in young people. Maybe we can use that very good tool or weapon that we have with a strict rules, maybe only in medical offices or with prescription, medical prescription, or with something like that, that we can use it. I think we can find a way to control the tool that we have, and we can measure the results from this use. I don't know if Effie Polyzogopoulou has something to add.
I agree with both of you. I think it's a cultural issue. So we have to focus on behavior measures more than from the governmental policies. Still, they have to be there, of course, but we have to focus on culture, on our culture. I mean, in every country, we have different cultures, but still, that's the point, according to my opinion, because especially in the young population as well, the same. And definitely, I agree that the future is in alternatives, like trendy gadgets, like to show in that it's not it's not the in health young, that it's not trendy, it's difficult, and maybe we can use social media, any other friendly way for them.
Yeah, I think, I don't know, Professor Lund, I think one way is to inform the adolescents about the effects, the detrimental effects of these products. And on the other hand, we have to inform the smokers about the detrimental effects of smoking itself and the other option, after they have tried the approved ways to cease smoking. This should go in parallel. That's my belief.
Yes, I surely agree. I think the dilemma between the concern for youth and the concern for smokers is perhaps best illustrated with the current discussions about flavors in e-juice. I mean, flavors in e-juice clearly attract youth, no doubt about that. But it also attracts smokers to switch to a reduced risk product. So, I mean, how should we weigh this? Youth will experience a moderate excess risk from starting to vape, while smokers will experience a huge reduction in risk by a product switch. So there's a trade-off here. So I think for regulators, it's hard. The dilemma is finding a sweet spot for regulation. So we have this discussion now in Norway. How should we regulate in flavors in e-juice? And this dilemma is coming up. And I'm sure you're familiar with it in other countries as well.
Right.
If I may add just one thing, I think that we need to see these approaches at regulation or promotion as something which is not fixed. It's like, you know, if you will, coming to Rome, there is plenty of restaurants. You go to a restaurant, you're not happy, you just move to another restaurant, or you can change your tastes. Maybe you go to Indian for 1 year and then you go to Chinese. The key point is that to be flexible and recognize that we don't want to see any longer people dying of lung cancer because they have smoked combustion cigarettes for 40 years. We don't want to see that anymore. So any tool which can move us towards that goal is going to be worth exploring.
Yes, there is a comment. Yes, I can see that there is a comment. Roberto Sasmat writes that making e-cigarettes attractive for youth is impossible without making them attractive to adult smokers. He said that is an Affidrom project that we have to focus both youth and adult, I think. What is your opinion?
Actually, I think a smoker is not choosing to smoke because of the flavor. He or she chooses to smoke because there is the effect of nicotine in the brain. On the contrary, young people choose to smoke just to be trendy, and it makes easier for them to use something that has some taste. So we cannot compare these two behaviors. They are totally different behaviors, totally different needs. That's why I think these products are very suitable for adults that smoke and they find it difficult to quit smoking, or they have an established disease and we don't need a second heart attack, or we don't need an exacerbation of a cancer, for example, rather than making it appealing for young people and generate the future and create the future generation of smokers.
Yes. The other question is from Stefan Madison, and he asked that how should we advise an adolescent smoker about the risk-benefit of vaping? That is a complex projection. We have to speak to them, to listen first to listen. him or her, and then to speak to them with saying the truth about smoking, the truth about e-cigarette, the truth about novel project. And I think that young people, they can listen. They can listen if you make them to understand that we are together. They don't want to be like to hear a talk about from her parents or from her teacher. Maybe if we can teach or we can use a peer education program, we can find another adolescents that they can they want to collaborate and to educate them, and they educate their teams. That's maybe it's be an approach, but I can hear from all of you other opinion.
Yeah, if I may add to that, Anastasia, I think it's kind of a twin track here. The important thing is to finding a channel that we can inform non-users of e-cigarettes and snus about the absolute risk of these products. But at the same time, we should also inform about the relative risk between the products, between cigarettes and e-cigarettes or snus, to those who are already smoking. So we should inform about the absolute risk, and we should also at the same time inform about the relative risk. That's my answer.
Okay, there is another question or statement from Fares Mili. There is a fear about the use of the nicotine delivered by the new products. There is a strong experimental evidence in both mice that clinically by the follow-up of smokers who switch to these products, to the evaluation of the truth that nicotine itself is not very addictogenic. It becomes so when it is accompanied by other molecules such as MAQ inhibitors. However, these molecules are present during the combustion of tobacco and very little with heated tobacco or vaping products. I think that Ferris Mili says that the new products are more safe than the tobacco use. We agree with that. I think all we have the same opinion. Is someone that can say something about that? I think that it was a statement, and
well, again, if I may, I think that we need to see this as something that can be customized, and also we can prioritize, for instance, introduction, implementation of MRPs, and then regulation, for instance, to ban vaping in certain places, or to pose limits to nicotine content. However, in the current phase, my perspective is that it's better to support the widespread use to overcome combustion dependence.
Okay, and we have something more, probably from Ferris Mili, that says that the majority of young people who use e-cigarettes are experimenters, are not daily users, and many do so without nicotine. I think also has right. Many of papers show that opinion. But I think that we need more surveys to see and measure that far as Millie says. Do anyone of us has know something else?
No, I agree, Anastasia. There are no studies, actually showing clearly that youngsters that use electronic cigarettes will become future smokers. However, this is a behavior, and we have to check whether in the long term these persons actually, that they have a mentality to use these products, will have the mentality to use tobacco in the future. So this is something that needs to be clarified. And people think that we sort of, how could we say, that this behavior becomes becomes justified, and because this is not a toxic product. However, this is something that needs to be proven during long-term use.
Yes, I agree. Until some years ago, there wasn't a question in the surveys what if the adults use e-cigarettes. In the last surveys, we found some question about e-cigarette or the other novel products. So we have to measure it. Okay, I don't know if Karl has to mention something else.
Well, I think we're approaching a close-up this session, and just could add some data from Norway saying that most young vapers in Norway are in fact using non-nicotine e-juice in their e-cigarettes, and we can't find any track, so any gateway effect in Norway from snus use to cigarette smoking or from vaping to cigarette smoking. In fact, our data indicate that those who are going on to smoke after they have vaped have much of the same characteristics that predispose them for smoking. So I believe there's a common liability theory beyond this association from vaping to smoking. And I totally agree with Faris Miller's statement here that the majority of young people who use e-cigarettes are experimenters and not daily users. And many do so without nicotine, and Norwegian data support that.
Okay. As I can see, we haven't any other comment in the chat. So if we have not something to add in our panel, we can stop here and to come again 15 minutes ago to continue our program. I want to thank you all for your participation, for your excellent presentations, and for excellent comments. I think we touched some very hot topics, and in future we have the opportunity to collaborate maybe in scientific surveys or programs or projects together via the SCORE Association. Thank you all for your participation.
Thank you.
Thank you very much.
Thank you.
Bye.
Thank you. Very nice presentations.
Bye.